Pulmonary disease associated with systemic sclerosis. Systemic sclerosis is a disease that affects women more than men. The ratio is 4 to 1, has HALA association and often presents in the fifth decade. It is largely a clinical diagnosis, and there are several types of systemic sclerosis. Include the following: limited cutaneous systemic sclerosis, diffuse cutaneous systemic sclerosis, the overlap syndromes, and systemic sclerosis, sign scleroderma, and environmentally induced cutaneous systemic sclerosis. The pulmonary disease and systemic sclerosis include the following: pulmonary fibrosis, pulmonary hypertension, chest wall limitation, organizing pneumonia, aspiration pneumonitis, bronchiectasis. The pulmonary fibrosis and systemic sclerosis seen at postmortem in up to seen at postmortem in up to 80% of patients. Antinuclear antibody is positive in 60% and of a speckled or nodular type. Pulmonary involvement is seen particularly if systemic sclerosis 70 antibody is present, CSL70 antibody is present. All antibody groups may develop interstitial-like disease, often more severe with anti-topoisomerase 1 antibodies. Microaspiration from esophageal dysmotility may be contributory. Present with dyspnea and a history of raynaud's. Examination signs of systemic sclerosis found by basal crackles. Pulmonary function tests show restrictive defect and reduced lung transfusion for carbon monoxide, KCO. Rapidly falling of KCO is a poor prognostic sign. HRC show mostly non-specific inflammatory, non-specific interstitial pneumonia pattern, but can be usual interstitial pneumonia pattern. Video-assisted thoracoscopic lung biopsy is rarely required unless concerned about other pathologies such as malignancy or vasculitis. Treatment with steroids, cyclophosphamide, or mycophenolate, mofetil, MMF, and randomized controlled trials of oral cyclophosphamide versus placebo in patients with active alveolitis and scleroderma related interstitial lung disease showed a modest but significant effect on forced vital capacity, dyspnea, and the quality of life. And randomized controlled study or randomized controlled trials showed comparable effects of mycophenolate, mofetil to cyclophosphamide on function on forced vital capacity over 2 years, and mycophenolate mofetil might be better tolerated in those with fibrosis, like DALIP shows that the reduction in FVC compared to placebo and has recently been granted FDA approval in the United States of America. Prognosis: systemic sclerosis associated interstitial lung disease have a better prognosis than idiopathic pulmonary fibrosis. This may be related to slower disease progression. Immune modulatory therapy shows slowed the progression, associated increased risk of lung cancer. Studies of antifibrotics are ongoing. Pulmonary hypertension and systemic sclerosis may be isolated or secondary to interstitial lung disease. Isolated pulmonary hypertension is characteristic of limited cutaneous disease, especially in those with cutaneous telangiectasias and anti-centromere antibodies, pathologically similar to primary pulmonary hypertension, and subintimal cell proliferation, endothelial hyperplasia, or the obliteration of small intrapulmonary vessels. Presents with dyspnea, right ventricle hypertrophy, and right heart failure. Diagnosis by echo or right heart catheter. Treatment as for pulmonary hyper as primary pulmonary hypertension and may respond to prostacyclin infusions or may need transplant. Prognosis better than those with pulmonary or primary pulmonary hypertension. Other diseases or other pulmonary diseases in systemic sclerosis include chest wall limitations via skin, which occurs via skin scleroderma over the chest and called hidebound chest. It is very rare. Organizing pneumonia, which is similar to organizing pneumonia, which occur in other diseases or the primary or idiopathic type. Aspiration neuritis, it's uncommon and due to esophageal dysmotility. Bronchiectasis is often seen on HRST, but much less commonly of clinical significance. Now we'll summarize the types of systemic sclerosis. The first type is limited cutaneous, which may have CREST syndrome. 60% of systemic sclerosis cases, the patients often have long-standing Raynaud's phenomena, developing non non-pitting edema of the fingers, which becomes saucer become saucer-shaped and develop thick, shiny skin after a few weeks to months. Later, they can develop skin traces on the hands, face, and neck, and microstomia, digital and facial telangiectasia, intra and subcutaneous calcifications, and esophageal dysmotility, 70 74%. Patients can also develop pulmonary fibrosis, 26%, pulmonary hypertension, 21%, and cardiac, 9%, esophageal, 90%, and renal disease, 8%, but less common than a diffuse cutaneous disease. The second type of systemic sclerosis is diffuse cutaneous type. It has abrupt onset disease with widespread symmetrical, itchy, painful swelling of fingers, arms, feet, legs, and face, and associated constitutional symptoms. There is edema, which is replaced by tight, shiny skin bound to underlying structures extending proximal to the wrists. Within few within a few months, there is cutaneous thickening as well as hypo or hyperpigmentation. Raynaud's phenomena is present as well as skin sclerosis on the trunk and upper arms, arthropathy, renal disease 80%, pulmonary fibrosis 41%, pulmonary hypertension 17%, cardiac disease 12%, and gastrointestinal disease 90%. Overlap syndrome or mixed cutaneous tissue disease have features of systemic sclerosis together with those of at least one other autoimmune rheumatic disease such as systemic lupus, rheumatoid arthritis, and over time other organ involvement may develop and evolve into a more definite disease. Systemic sclerosis with scleroderma, which is the fourth type, vascular or fibrotic visceral features without skin scleroderma, and may or may not have Raynaud's phenomena, and may develop interstitial lung disease, esophagitis, arrhythmia, malabsorption, pseudo-obstruction, renal failure in about 2% of cases. The last type of systemic sclerosis is environmentally induced contin- contagious but may result from exposure to vinyl, vinyl chloride, pesticides, or epoxy resins. Pulmonary complications are the most common cause of death of systemic sclerosis. That's all, and thank you.